Hi everybody, welcome once again to AARC's Big Ideas Theater. I'm your host, Ed Heiland, and I've got the honor now of being joined by Alex Rotta, who was the speaker at Saturday's session on the mechanical support for status asthmaticus. Thank you so much for coming by and sharing some thoughts with us, if you would.
Thank you for having me, Ed.
Tell me a little bit about what should be the goal of mechanical support of a child with critical or near fatal asthma.
So that is an issue that should have been settled a long time ago, but and yet we see every day in pediatric intensive care units around the country people taking the wrong approach. When you translate mechanical ventilation from just pure respiratory failure or ARDS and try to apply that to the asthmatic child, things can go very wrong because the goals are quite different. In critical asthma, we're really not trying to influence the course of the disease. We're just trying to support the child with the minimum amount of support and not get in the way, because if you try to correct all the blood gas abnormalities and hyperinflation abnormalities, you're likely to get into more trouble. For you to have an idea, 20 years ago, when a child or an adult for that matter were intubated with status asthmaticus, 1 in 4 would die from complications of mechanical ventilation. And just by using a gentler approach that doesn't seek to correct the carbon dioxide or the hypercapnia, permits hypercapnia, in fact that's desirable, mortality is virtually zero these days.
Well, speaking of gentler, what is the preferred mode for dealing with children?
So the mode is actually less of an issue. You have various modes, and whatever mode you choose, you have to choose a strategy. So if you choose a pressure-controlled mode, for instance, that mode has a decelerating flow and a constant pressure. You will choose that with a reasonable inspiratory time and a very long expiratory time so that you allow for full exhalation. If you choose a volume control mode, that has a constant flow waveform and a triangular pressure waveform, and what you will do is essentially follow peak and plateau pressures, again allowing for ample time for exhalation so that you avoid hyperinflation. So it really depends on whatever mode you're going to choose. You got to choose a strategy that best fits your patient.
Give us a detail on what is the role of PEEP, for example, in children with near fatal asthma.
PEEP is one of those complex parameters on the ventilator of on the ventilation of the asthmatic child, because PEEP as in positive end expiratory pressure is something that will maintain lung inflation, which is actually the problem you're dealing with in asthma. A child that is being ventilated is already hyperinflated. So applying PEEP will only increase the hyperinflation that you already see. So for the patient that is ventilated and paralyzed, so under neuromuscular blockade, PEEP should not be used. And that is a very big jump for most practitioners, because we are so programmed to use low levels of PEEP, medium or high levels of PEEP, but never zero PEEP. And in the intubated paralyzed asthmatic, PEEP should not be used. Any PEEP that is given will increase hyperinflation. Now, for the patient that is now spontaneously breathing and yet intubated, applying PEEP will help synchrony with the ventilator, so we'll use as much PEEP as necessary to kind of match the patient's auto PEEP and allow for better synchrony, and patients feel much more comfortable that way. So no PEEP when you're paralyzed. Start applying PEEP, usually less than 8, mostly between 4 and 6, to try to match the patient's intrinsic PEEP and improve synchrony.
It sounds like it's an area where you're still learning. I would say experimenting, because we don't do that with patients, but it sounds like an area where you're still learning and still getting the feedback needed to start coming up with the parameters for the future, the next generation, if you will.
Actually, the knowledge in asthma has been settled over 20 years ago, and is just, it is such an antagonistic approach to what you see in pneumonias, ARDS, and pure respiratory failure, that people have sometimes suffer from confusion, as in, well, we apply these paradigm to all these diseases, and asthma is a completely different paradigm. So the knowledge has been settled. We're really just trying to talk about that to raise awareness that a patient with severe obstructive disease is very different than those with a disease of compliance like ARDS.
Well, Dr. Rotta, thank you for enlightening me and our audience as well here on the Big Ideas Theater.
Thank you very much, Ed.
And this is AARC's Big Ideas Theater. I'm Ed Heiland. Thanks for joining us.